Okay, so I think we will initiate the proceedings. So, hi everybody. Thank you for joining us today. We are back with the second season of the Indian Academy of Neurology Young Neurologists Forum. This is an excellent platform that has been given to the young neurologists who are life members of the Indian Academy of Neurology, so that we can hold sessions and we can discuss things that are of importance to young neurologists. So we are back with our first episode, and today we are going to have a case-based discussion. We have two cases in the offing, and let us begin. So for this, I would like to first invite our moderators. So among the senior moderators, we have Professor C.B. Gopinath, who is a professor and program director at Amrita, Kochi. And among the moderators from the YNF, we have two people. First is Dr. Rutul Shah, who is a consultant neurologist and epileptologist from Ahmedabad, and we have Dr. Sindhu, who is a consultant neurologist and epileptologist from Bangalore. So I will be handing over this session to the architect of today's program, that is Dr. Rutul, so that he can proceed with the event for today. So over to you, Rutul.
Thank you very much for the introduction, Viviani ma'am. Welcome everyone. Today's program, we have a theme which is epilepsy. So we have two epileptologists, Dr. Abhishek Gohel and Dr. Mihir Parekh, who will be presenting two very interesting cases to all of us. And I'll hand over the mic to Dr. Sindhu. She will introduce Dr. Abhishek Gohel, and we'll start with the case of Dr. Abhishek Gohel. Thank you.
Good morning, everybody. Thanks for joining us. So I'm privileged to welcome Dr. Abhishek Gohel, who is a colleague of mine as well. So he did his DM neurology from Nemans, and then post that he did his fellowship in epilepsy at Amrita Institute. So I would invite him to start off the case.
Thank you, Dr. Sindhu, and thank you everyone for giving me this opportunity. We'll just start with the case.
Just a minute. Sorry for joining late. I'm Dr. Devashish here.
So welcome.
Yeah. Good morning. Sorry for joining late. So I would just like to compliment the Young Neurology Forum, and it's a wonderful activity. And I think we should have some. I had a talk with Devyani. We should have some modification of the content of the program. But this time we have this case presentations, and I hope that everyone will have an enjoyable time and a great learning experience. I have some other meeting to attend, so I'll just say hello to everyone, and thank you for inviting me. Thank you.
Thank you so much, sir, for joining us. Thank you.
Thank you, sir. We'll go ahead with the case. So the first case for today is of 8 months old boy. He was born normally on consanguineous parentage by full-term normal vaginal delivery. He had cried immediately after birth and with a normal birth weight and without any history of parental insult, immediate ICU admission. Then he started having seizures at 1.5 years of age, 1.5 months of age, and now total duration of illness is 6.5 months. These seizures were, as reported by the family, were characterized by facial deviation to left side and jerking of left hand and leg with some posturing. He had daily such episodes, around 5 to 6 per day, and both out of sleep as well as in awake state. And rarely they were bilaterally synchronized. This bilateral synchronization, that is what we call secondary generalization usually, is happening more often of late. Since last 1 or 2 months before the presentation, these were more frequent. Otherwise, no family history of seizures or febrile, no history of febrile seizures or status epilepticus. And at the first contact, he was on 4 anti-seizure medication, including brivaracetam, clobazam, oxcarbazepine, and valproate at adequate dose. And examination-wise, he did not gain any milestones. There was no head control, no vocalization or social smiling. There was no eye tracking, and there was no obvious asymmetry in the movements of the limbs. He was moving all 4 limbs without any predominance. So our working diagnosis at the end of history and examination was an infant that we are dealing with an infantile epileptic encephalopathy with some focal features. And probably that gave us, and these focal features were very consistent. Okay, it was not variable from one side to another side or something of that sort. So that gave us a pretty good lateralization to right hemisphere, and probably some localization in premotor, motor, or opercular areas as characterized by facial deviation and left upper limb, lower limb, tonic and then clonic movements. So based on all this, we went ahead with video EG. And as we can see over here, we have spikes and followed by waves. So spike and wave discharges, which were uh, uh, more better formed over right. The red is right. So F8 and T4 more than FP2, F4, C4. So right and anterior temporal region and with field extending to frontocentral region, right frontocentral region. And this were spike and wave discharges. So they were like epileptic. And these were very frequent, occurring out of sleep as well as in awake state. I'll show one more. And there is clear cut. The background, the after coming background is disturbed after these discharges. So this was the interictal record. I'll just reduce the volume. The child is crying and moving all four limbs. And then he stops. He stops crying. And then there is posturing of both the upper limb and lower limb. And just before it starts bilaterally, there is some left hand fisting, which lasts for just a few microseconds, I would say. And then there is obvious asymmetry. Left upper limb is extended over here. And then towards the later part of the event, we have facial jerks and left upper limb jerks, and then left lower limb jerks, which are very, very rhythmic. So this was a confirmation of the historical finding that left upper limb and lower limb were clonically correlate. And as we can see, this is this here is the clinical onset over here. And before that, we have some 5 or 6 seconds of dampening of the ongoing interictal activity. This is the interictal activity without any obvious asymmetry over the rights, over both the sides. And then we have dampening of ongoing interictal background. And there is a clear-cut suppression over the right hemisphere, more so in right frontotemporal region. And then I'll go to the next page. We have fast activity, which is seen over both the sides, over the right frontotemporal F8 and T4, as well as just I think half a second after that, it is seen more clearly over F7 and T3 also. But as we go ahead in the ictal discharges, we have very well formed ictal activity over F4, C4. It spreads with fast activity continuing over the same. And there is it is better formed over the right hemisphere than the left hemisphere. Obviously, left hemisphere is also involved by this time, but it is better formed over the right hemisphere, and it remains faster over the same. It continues. It continues to evolve into it remains faster over the same hemisphere also. And then we have post-ictal slowing bilaterally. So after the video EG, that is history, examination, interictal, ictal, video and EEG demonstration, this is the AEC that we came to conclude. That is, we were dealing with probably a structural epileptic encephalopathy. and with lateralization to right hemisphere, more likely to be premotor and motor region. So with this working diagnosis, we went ahead with a harness protocol MRI. I'll just briefly take a slight detour to explain what is harness protocol MRI. Now, this was given by MNI, that is Montreal Neurological Institute, the brain, that is Nida Bernasconi and Andrea Bernasconi. They are doing pretty good job in dealing with MRI negative epilepsies. So this protocol was standardized by them. It has been adopted by ILE. What is it? So it is volumetric sequences, 1 millimeter by 1 millimeter by 1 millimeter, volumetric full brain sequences acquired in T1 as well as FLAIR. The T1 acquisition should be in sagittal region with sagittal it should be a sagittal acquisition ear to ear spanning the entire brain, and the flare acquisition, it should be a coronal acquisition. Why is flare acquisition important? Usually when we ask for an epilepsy protocol MRI, some of the centers they do only T1 volumetric acquisition and they do not do flare volumetric acquisition. Why it is important to acquire it in volumetric as well as volumetric sequences as well as coronal acquisition? Because we need to look for tail signs that are better visible over coronal and in the flare. And when we have a tail sign on in an FCD, we are likely to be dealing with FCD type 2B. And even when it is absent, there can be some thickening or blurring junctional abnormalities in gray-white matter interface. So that can also be a suggestive of focal cortical dysplasias, and they are better visible in volumetric sequences than that. And along with this, we do T2 coronal acquisition with a focus on hippocampus, spanning the entire till the tail of the hippocampus, and entire corpus callosum has to be acquired. And we can do asymmetry analysis in that also to look for any hippocampal sclerosis. This acquisition, we should be categorically stating to the neuroradiologists involved in the acquisition that there has to be no interslice gaps and there should be no movements. If if it is done under supervision of a neuroradiologist, so we did not say it to them because they obviously know that this has to be done like that. But in case a center which is not that well equipped with such protocol, then we need to categorically state it to the technicians involved as well as the doctors involved in it that there should be no movements. So when we ask for no movements, the anesthesiologist thinks that there should be no visible movements. For a technician, it has to be a movement. It should be devoid of movement artifact. And the definition of no movement for an epileptologist, it is completely different. So there are different thresholds for different people involved in the process to define something as no movements. So we need to categorically state it to them that absolutely no movement is allowed in this case, because we are looking for something very focal. And if you are blindfolded, you cannot call something MRI negative, right? So this is why it is so important. It is very easy to call something MRI negative if you're not looking at it. And when we get these images, we need to ask them to send us a DICOM images. Just looking at the plates is not enough to call something MRI normal. Okay, we need to look it at themselves by ourselves, and the neurosurgical team has to be involved to look at it, and then they can find some things that we have missed, or the or the radiologist involved has missed. Okay, so because of all these things, I'll just show the MRI. Just give me some.
While Abhishek is looking for the image, I welcome Dr. Meenakshi Sundaram and Dr. JMK Murthy on the panel. And thank you so much, both of you, for joining us today. Thank you so much.
Hello.
Hi. Is the screen visible right now?
Yes, sir, it's visible.
Okay. So let us look at the axial acquisition. So let us look at the axial acquisition over here, and I'll go slowly inferiorly. Okay. So we go step by step, looking at each cut nicely. And as we can see, there is some obvious asymmetry between the left hemisphere and right hemisphere. So this is a radiological view where the right is left, left is right, normally as we see on the console. Okay. As we go down, there is a abnormal cortex over the right frontal region, as we can see. And with abnormal white matter also, there is obvious asymmetry between the two. There is sulcation abnormality. And the gyrations are not as well formed over the right frontal region. We go further down. There is a white matter abnormality, and over the and similar cortical abnormalities over right temporal region also. In fact, the right temporal region is almost like devoid of a visible white matter, as we can see over here. Now we go similarly over the coronal cuts. I go posteriorly from anterior. As we can see, the right hemisphere, the white matter over the right hemisphere is abnormal. And gyration abnormalities over the same. So it confirms our finding on axial. So based on the radiology, we were dealing with, we came to a conclusion that we were dealing with a multi-lobar dysplasia. Okay. So let us go back to our presentation. So we went ahead with genetic testing, and whole exome sequencing was done. It showed NPRL3 mutation that was a pathogenic variant, and it was explaining the clinical as well as radiological findings in this case. So what is NPRL3 mutation? We will do review of literature after this. But and I will just briefly touch upon it, that it is an abnormality in the pathway of neuronal migration and maturation, which leads to the abnormality of which leads to focal cortical dysplasias. So this gave us a clue that we are dealing with focal cortical dysplasia. So what are the options now available? So yes, it is a structural pathology with genetics positive. And so what are the options available? Should we go ahead with multilobar disconnections, that is right frontotemporal disconnection, or should we go ahead with right hemispherotomy, or we should go ahead with stereo EEG to localize the epileptogenic lesion? What we knew is that we are dealing with a structural epileptic encephalopathy. The child has not gained any milestones, and he is an infant. with an FCD. So typically the epileptogenic zone of an FCD exceeds far beyond and much wider than the anatomical correlate or the anatomical abnormality that we are finding on radiology. That is first thing. Next is the child is having an epileptic encephalopathy. So he's practically on the floor. There is only something to gain now. And third is that the age was on his side. That is, if we intervene early enough, say for example, within 1 year or 1.5 years or 2 years, then we have a very nice neuroplasticity wherein the contralateral hemisphere can nicely take up all the essential functions, and the child can be normal. So that is why we went ahead with right hemispherotomy. And this is a histopathological report. As we can see over here, there is dysmorphic neurons, and there is cortical dyslamination on new and stain, as we can see over here. And IHC and everything, because and there is absence of balloon cells. That is how we have diagnosis of FCD type 2A. We were dealing with FCD type 2A. And clinically, he is Engel 1A, that is seizure-free, completely seizure-free at 6 months follow-up. And he started following simple commands. He is able to sit with support, and he is moving all 4 limbs. So what happens is, after right hemispherotomy, he had, because there is a disconnection, right? So he had a transient left upper limb and lower limb weakness, and which improved over next 10 to 15 days. And then he's okay right now. So this concludes our case for today. Subsequently, I'll be talking about the review of literature, why we did what we did. So FCD, development of FCD is a story of migration and connectivity abnormalities. As we can see over here, these neurons, during the brain formation, these neurons periventricularly situated, they migrate outwards. To become the cortex, to become the final cortex. And once they have migrated outward, there is a tangential connectivity between, there is tangential connectivity between between all of them. So there are two forces working over here. First is a radial force, and then we have a tangential force. So migration is radial and connectivity is tangential. When it is too loosely connected, we have listen carefully. And when it is too tightly connected, we have polymicrogyria, as simple as that. And when we have both, we are dealing with a multilobar dysplasia with somewhat polymicrogyria and somewhat of listen carefully in it. Also, not only that, we need, when it happens, when the variant kicks in, that also matters. If the variant occurs in early stage of development of brain, we have more widespread abnormality. If it occurs too late in the brain formation, then we have a focal abnormality, as we can see over here. So practically, we are dealing with a spectrum. So this is a periventricular heterotopia, nodular heterotopia, PNH. That is when the migration has not started at all. We have subcortical heterotopia, which is a common finding in tuberous sclerosis, and where the arrest of migration has happened somewhere in the midway between the cortex and lateral ventricles. Sometimes it happens as a band heterotopia. That is LIS1 and DCX structural abnormalities. Then we have abnormalities in tangential. So as we discussed, it can be polymicrogyria if it is too tightly connected, and listen carefully if it is too loosely connected. And then we have island abnormalities. That is at the intersection of radial as well as tangential. We have focal cortical dysplasia. That is focal irregularities of cortical morphology, and the gray-white interface is indistinct. And there we have all the mtauropathies and gatoropathies. So what it is? What is all mTOR pathway and Gator pathway? I'll briefly touch upon it. So basically, we have three pathways over here. First is RAS-RAF MAPK signaling pathway. Then we have mTOR signaling pathway. And then we have Gator negative signaling pathway. An abnormality of this pathway, RAS-RAF MAPK pathway, it leads to tumors, benign tumors like ganglioglioma, epileptogenic tumors, ganglioglioma or DNETs. And these are more frequently seen in temporal region. Abnormalities of mTOR pathway, that is tuberous sclerosis complex and mTOR pathway abnormalities and all, they are typically FCD type 2B and they are seen in frontal region. And Gator pathway abnormalities, they are typically FCD type 2A. We do not find a tail over there and there is no ballooning over there. So what it is? mTOR pathway. Say for example, I want to develop a FCD in a particular brain of an animal or a mice. So what should I do? I should be activating the mTOR pathway. So to activate a pathway, we need only one mutation. Only one mutation is required. And so that is why these are usually heterozygous and these are usually somatic mutation. So constitutional mutation might not be required for this. So only a somatic mutation, a local mutation is enough to cause all these things. That is why FCD type 2B are usually MRI negative, genetics negative if the sampling is done from periphery, that is blood. Gator pathway is a negative signaling pathway. It inhibits this mTOR pathway. So to inhibit, to stop this negative signaling, I need to have two mutations. Okay, so for two mutations, I need a constitutional mutation that is in blood, and I need a second hit in form of a local mutation. So Nelson's two-hit hypothesis comes into picture over here. So when we have an FCD with a genetic mutation in these three genes, it should be positive from the blood irrespective. That is the lesson over here. So in case we are dealing with an FCD and blood is and genetic test, whole exome sequencing for this or next generation sequencing for this is negative, then we are not dealing with a gatoropathy. We might be dealing with an mTORopathy with mosaicism or something of that sort. So this three pathway. First is RAS-RAF MAPK, where we have temporal, usually in temporal region, benign tumors. Then we have mTOR pathway. We have FCD type 2B tumor, FCD type 2B, that is dysplasias in frontal region usually. And we have gatoropathies, that is a negative abnormality in the negative signaling pathway for mTOR. And that is FCD type 2A. So mTOR pathway regulates cell growth, proliferation, and survival. And so only one single hit is required. So somatic mutations are enough to cause FCD type 2B. And its hyperactivation causes malformation of cortical development. And it occurs after, usually somatic mutations occur usually after fertilization. And that is why in peripheral blood, it might be missed. So how do we confirm it that this is a mutation? We need to do deep sequencing at 1000x of the brain tissue that is excised and selected by a neuropathologist. And Gator pathway abnormalities, it is an abnormality in these three genes as we discussed, and they share a final pathway to FCD formation. And for that, we require double hits. First hit has to be an inactivating mutation in constitution that is present in any and every cell of the body. Next is a somatic loss of function mutation in the second, as a second hit. That is in the brain, say for example, if you are dealing with an FCD. And loss of function mutation in both of this leads to hyperexcitability and seizures. So again, and then we have a non-mTOR pathway, that is MOGI. And it is said to be, it is found to be associated with an abnormality in SLC35A2. Why it is important? Because It can be helped the patients with MOGI, that is, they present with infantile spasms, and they can be helped with targeted medicine like galactosamine supplementation, and with fairly good results, as well as with surgical, obviously. So this is the gene panel that we had advised for, we had asked for in this patient, and which contains all the MCD associated as well as mosaic mutations, and with a special mention of RHEB as well as SLC35A2. Both the genes have been reported by Ingmar Blumke recently, and out of this one is can be helped by medicine also. Now, the problem is not genetics. Problem is MRI. Okay. So the more focal a lesion, the better the MRI acquisition and interpretation has to be to detect it. It is as simple as that. So after we look at the MRI, we can and genetics, we can ask, we can opine that the patient is a surgical candidate, and obviously video EG, whether it is a surgical candidate or not. And why is getting genetics important in structural pathologies like this, that is malformation of cortical development? Because in case of gatoropathies, we have a lesser degree of post-surgical seizure freedom, that is 50 to 60%. And in case with bottom of sulcus dysplasia, it is 80 to 90%. So when we are not dealing with bottom of sulcus dysplasias, the seizure freedom is only limited. Why it is so? Why? Because when it is a gatoropathy, one thing is for sure, that we are dealing with a constitutional mutation. And that means there can be a small lesion somewhere in the brain that is MRI occult, that might be missed. And or it might it might become epileptogenic in future. That limits the seizure freedom. But that does not mean that surgical is not an option. It means that you can prognosticate the patients better in terms of post-surgical outcome. So this is a genotype-phenotype correlation as per the neuroimaging. That is what we discussed. FCD type 2, type 1, that is just dyslamination. That is all. Next, we have FCD type 2, that is dysmorphic neurons. Type 2A means without balloon cells. Type 2B is with balloon cells. Then we have FCD type 3, then other abnormalities like MOGI and all. So this is a thing. The more focal a lesion, the more MRI negative it can be. So a better MRI acquisition and interpretation is required to diagnose this. The more widespread the lesion, the more severe the epilepsy will be. And in cases of constitutional mutation, that is DEPDC5, entire body is affected, but epilepsy might be the only manifestation in such cases. So let us now just conclude today's session, that genetics does not preclude surgery. It can help in prognosticating post-surgical outcomes in such cases. So it can definitely supplement our, it is one more tool, one more layer added to our pre-surgical armamentarium. These are my references. Thank you so much.
Thank you, Dr. Abhishek, for that crisp and excellent presentation. And congratulations on handling this case so well. And the review of literature was quite descriptive and very informative indeed. And I just have a few clarifications. The interictals were not present on the left side at all.
They were not present on the left side. Yes, I'll just show. They were not there.
They were not there at all. Okay.
They were not there at all.
And one more thing is, did you consider a PET CT in the case, or because it was a clear-cut MRI showing right side pathology?
When we, lesion was very much visible. and we had a clear-cut hypothesis that a wider and more aggressive surgery will be better at this age for this patient. So that, I mean, what is the extra utility of PET at this point of time? The only extra utility of PET was if we wanted a more focal resection. That was the only extra utility, right? So that was not the case over here. And just sparing the right occiput at the cost of a very active a genetic etiology FCD.
Absolutely right. I was just considering the possibility of hypometabolism or just hold on the other side just to give a further prognostication of seizure freedom.
Okay. Over the contralateral side, over the left side. Okay.
Yes. But anyway, it's a very good job, Madam Jampan.
Thank you so much.
Yeah, the case is open for discussion. We have a question,
Excellent.
Dr. Meenakshi. Sir asked if the genetics of the parents was done.
Okay. So we have asked for Sanger sequencing in this case of both the parents, and they are like in the process of doing it. They have not yet agreed for it, but they are in the process of doing it. So within 1 or 2 months, they might be ready with it, and then we might have Sanger sequencing for this.
Excellent case, Abhishek. I would like to invite Dr. Siddhi Gopinath ma'am to give her inputs on this case.
Ma'am, please unmute yourself.
Yeah. Thank you, Abhishek, for that excellent presentation as usual, and the excellent slides and depiction of making genetics so simple. So that is like it's a very rare situation where genetics become so simple. So very congratulations for that. So I think this case is very conveys to me. It conveys few important messages like early detection of an epileptic encephalopathy. And even when the semiology, yes, there was some structural, some asymmetry, and picking up that asymmetry, picking up that it is epilepsy and child is in encephalopathy with a structural MRI abnormality, and going ahead with surgery is like very, very commendable, and it has to be done. And it is like, it reverses it. It makes the child's cognitive, the possibility of cognitive development very, very good. So that is that. Second is why did you, so you have already very well stated in your presentation why you did an genetic test in such a case. So probably when we have such an extensive lesion on the MRI and everything is concordant and you don't have any other red flags as much in the history, we would not have gone for a genetic test. But as you very well said that you would like to know what the genetic status is, and probably it would prognosticate that the seizure outcome. And as you got in this particular case, a gene that is very well described with one of those gataropathies and the type of focal cortical dysplasia. So the genetics is concordant with the syndrome and with the radiology. So you have a tool for prognostication also. So that is also like, yes, it is usually not done, or only in few centers with very great interest in genetics they would have done. But in this case, this would add on to your your expectation of what the seizure outcome would be. And the case of like the PET scan, yes, very well explained that probably PET would have shown a probable global hypometabolism of that hemisphere and maybe on the contralateral side also. But then, as you said, in when the structural abnormality is so huge and it is multilobar and it is almost extending to the parietal and the posterior temporal region. So hemispherotomy would have been the only choice, and PET may not actually add on to anything. So with that, yeah, again, congratulations for the excellent presentation.
Thank you, ma'am.
I invite Dr. Sita Daitya Madam and Dr. Murthy sir as well to give their valuable input.
Sorry, I joined late. So
I invite Dr. Meenakshi Sundaram sir to give us valuable inputs about this.
Hello. Can you hear me?
Yes, sir, we can hear you.
Okay. No, it was an excellent case. I actually enjoyed the way in which it was taken through.
Thank you.
And I was just wondering about only that, the genetic part. Because when we normally end up as movement disorders, we always keep getting this. We end up with a VUS, the autosomal dominant, especially, then we would need a confirmation with the Sanger Brown sequencing and all.
Yes, sir.
All in all, very good, very well done. Thank you.
Thank you. Thank you.
Thank you very much, Dr. Abhishek, for an excellent presentation. If we don't have any further questions, should we move ahead with the session and invite Dr. Mihir Parekh, who is a consultant neurologist and epilepsy specialist from Vadodara. He has done his DNB medicine from DNB neurology from Bangalore, and he has done his fellowship in epilepsy from Hyderabad with Sita Jalakshmi ma'am. And I would like to invite Dr. Mihir Parekh to present his case.
So, good morning, respected teachers and my colleagues, and thank you, Indian Academy of Neurology, for giving me this opportunity. So, after an excellent case by Dr. Abhishek, let us move on another case. So, our patient is a 17-year-old girl who is right-handed. She has normal birth history. She is a second child who is born of non-consanguineous parents. She has normal birth and developmental milestones. She don't have any family history of epilepsy, no history of any febrile seizures or encephalitis, and there is no history of head trauma in the childhood. Her epilepsy started at 9 months of age, and currently she is 17 years of age. So duration of epilepsy is pretty long. It is 16 years of duration. She gets focal onset impaired awareness motor seizures, in which she don't get any aura. It starts with behavior arrest. Then she has right upper and lower limb automatisms. She has left upper limb posturing, and she is amnesic for the event. So these are a bit prolonged events. It lasts for 60 seconds to 90 seconds. There are very frequent recently, daily 3 to 5 times per day for last 1 month, daily twice for last 2 years, and before that it was 2 to 3 times per week. Very infrequently she has secondary generalization at the onset. It used to occur during both awake and sleep. There is no history of status epilepticus. In beginning, she was 2 years seizure free on carbamazepine. She is already on given 7 to 8 anti-epileptic drug trials. So as we know, as per International League of Epilepsy, she is a case of drug-resistant epilepsy. So she is talking to her parents. She suddenly gets behavior arrest. And if we can focus on her face, she has this unpleasant facial expression with fluttering of the lower lip. If we can see, there is automatisms predominantly in the right lower limb right now, and posturing of the left upper limb. Now also she has the continued behavior arrest with right upper and right lower limb automatisms. There is some eye deviation towards right side. She is still not responding to any response testing. And there is some automatisms continue of the right upper limb. So it is almost 80 seconds. She is still confused. So without stopping medicine, we did EEG for 2 days, and we could record around 9 seizures. I'll just show one more simiology. She is talking to a technician. now again started. She has this unpleasant facial expression with puckering of the lower limb, right upper and right lower limb, predominantly automatisms with behavior arrest. There is deviation of eyes towards the right side. And these are also prolonged hypomotor seizures, which last for around 90 seconds. Okay. So what we have upper and lower upper limb posturing, she has right upper and lower limb automatisms. So she has focal onset impaired awareness motor seizures without any aura. So she is a case of drug-induced epilepsy with lateralization towards the right hemisphere. So what we have seen is we know prolonged hypomotor seizures with behavior arrest, automatisms and posturing, though we see more commonly in temporal lobe epilepsy. However, ictal pouting at onset, it is more favoring towards frontal lobe. So that's why even though semiology is more looking like temporal lobe epilepsy, so exact localization we have not kept at this point. Plus, she had a deviation of the eyes towards the right side, and here we have lateralization towards the right hemisphere. So as we know, whenever there is symptomatogenic zone involved in the frontal eye field, the eye deviates to the opposite side. But whenever the network spread through temporal occipital region, there can be ipsilateral eye deviation. So now, few things about ictal pouting. It is also called Charcot-de-Janmet sign. What it is, this is the largest series of 11 patients in which ictal pouting is called a symmetrical sustained lowering of labial commissures with contraction of chin. The name comes from head of a Janmet. It is a French policeman at Napoleon times, in which the seizures are more of localized towards intercingulate, mesial prefrontal, orbitofrontal, or insular region. So this patient underwent video EEG, and we have our lateralization towards right hemisphere. So this patient, this is the interictal data of the patient, in which if we can see, there were very frequent right frontotemporal interictal discharges with maximum phase reversal at F4 and T2 T4 region. Also, if we see intermittently, there was polymorphic theta range slowing, which was evident in the right predominantly temporal and intermittently right frontotemporal region. So throughout the interictal record, we could not find any spikes on the left hemisphere. So interictal data was predominantly right frontotemporal region. During the seizure onset, we can see there were pre-ictal spikes in the right frontotemporal region, and then there was rhythmic theta. However, after 5 seconds, there was myogenic artifact because of the movement of the patient. I'm not shown full seizure, but here also we can see during the seizure there was rhythmic theta activity involving right frontotemporal region. So ictal onset was after night seizure, right frontotemporal region in the 7 events and right temporal region in the 2 events. So we did MRI, brain epilepsy protocol, as Dr. Abhishek has nicely mentioned. So it was showing predominantly right hemispheric dysplasia. What we can see in this slides, there is no proper gray-white differentiation. Even Sulcar-Gaira pattern are not clear in the full right hemisphere. We can see from the high frontal cuts to above, full right hemisphere was almost hypoplastic. These are the flare images. Axial. These are coronal and sagittal images, which is again correlating with our finding. It is a hemispheric dysplasia in which right hemispheric was completely hypoplastic. These are the T2 images, which is also showing the same findings, which we saw earlier. And the T1 images, the same. So we did a PET scan of the patient. So if we see the right hemisphere, predominantly temporoparietal region was showing moderate hypometabolism, and right frontal region was showing mild hypometabolism compared to left side. So it was correlating with our interictal, ictal, and MRI data. The right hemisphere was showing less metabolism compared to left hemisphere, though temporoparietal region was showing more hypometabolism. However, HVC or neurology results mainly in the history and examination. So there are a lot of important findings on examination of this patient. So if we see here, there is a linear hypopigmented patches were seen on the right arm, right forearm, right leg, and right thigh region. They noticed it after 6 months of age. They were not present on the left side of the body. So it was present only in the right upper limb and right lower limb. Also, what she had this finding is polydactyly of the right foot, in which was operated in the earlier age. So that was the extra finger in the right side of the leg. The picture is a bit blurred. What I want to show you in this picture is if we compare right upper limb and left upper limb, and right lower limb and left upper limb, there is hypertrophy of the right upper limb and right lower limb compared to left upper limb and lower limb. It is clearly seen in this photograph. So I'm just summarizing the finding. So we have a young girl with phacomatosis with drug-resistant epilepsy, in which she has hypopigmented patches over the right side. There is hypertrophy of the right upper and lower limbs. She has polydactyly of the right foot. She has seizures which are focal onset, impaired awareness, motor seizures with ictal pouting, suggestive of right hemispheric lateralization. Interictal and ictal EEG data suggestive of right frontotemporal focus. MRI brain is showing right hemispheric hypoplastic, and PET CT is also favoring right temporoparietal more than right frontal hypometabolism. So we are dealing with a case of phacomatosis with epilepsy. So whenever we thought of phacomatosis with epilepsy, these common things which come in our mind, whether it is hypomenasis of Ito, whether it is Menkes syndrome, whether it is Sturge-Weber syndrome, whether it is tuberous sclerosis, or whether it is neurofibromatosis. So the diagnosis is what the patient has is hypomenasis of Ito. So what it is called pigmentary mosaicism. What is mosaicism? Mosaicism means single zygote. They produce two different cell lineage with different genetic expression. So this hypomenasis of Ito, it is third most frequent neurocutaneous disease. Overall, worldwide, the prevalence is 1 case per 82,000. However, it is most prevalent in Italy, where it is seen 1 in 7,500 cases. In this patient, there is distribution of two different cell lines with different pigmented potential in single individuals. So there is a clone of skin cells with reduced capacity of melanin production in this patient. So what is peculiar in this patient is what we see in this picture. There is a hypopigmentation follows these lines of Blaschko, and this lines of Blaschko doesn't follow any anatomical or any vessels. So they are called the lines that represent migratory pathways for fetal epidermal cells. So the hypopigmented patches follows these lines in these patients. Most cases are sporadic. However, chromosomal mosaicism and chromosomal translocation has been reported. As far as neurological abnormalities, most common condition is unilateral cerebral hypoplasia, which we have seen in our patients. Then hemimegalencephaly. They can have lissencephaly. They can have gray matter heterotopias. For musculoskeletal abnormalities, most common abnormality is hypertrophy of the one side of the limbs. Others are scoliosis, cord spaces, abnormal digits, and few patients can have extra musculocutaneous and extra neurological manifestation in the form of single kidney, cataract, ptosis, congenital heart disease. So regarding diagnosis, it is a clinical diagnosis. The criteria were established in 1996, which is largest series. 41 cases were reported, in which they have mentioned the essential criteria is congenital, early or acquired, non-hereditary cutaneous hypopigmentation, patches involving more than 2 body segments. Major criteria involves 1 or more nervous system abnormalities or 1 or more musculoskeletal abnormalities. And minor criteria involves 2 or more other congenital abnormalities like ocular, cardiac, or renal manifestation, and chromosomal abnormalities. So for definitive diagnosis, we require criteria A plus single criteria B or 2 criteria C. While our patient is criteria A plus 2 criteria B. So she has a diagnosis of hypomelanosis of ETO. Now she underwent genetic testing. The whole exome sequencing was negative as we expected, and also she underwent chromosomal analysis by karyotyping, which was showing a normal female karyotype. Now I will just briefly go through some literature of neurocutaneous syndrome which are associated with epilepsy. So as we know, most common neurocutaneous syndrome is neurofibromatosis, second most common is tuberous sclerosis, followed by hypomelanosis. But as far as epilepsy is common, what we heard commonly is tuberous sclerosis. So in tuberous sclerosis, 80 to 85% patients have epilepsy. And out of them, more than 80% are drug resistant. They have commonly hypomelanotic macules, they have shagreen patches, they have adenoma sebaceum. In MRI, we commonly see tumors, subependymal giant cell nodules, and SEGA. Regarding management part, there is now involvement of targeted therapy, like mTOR pathway we target, and everolimus we can give to patients, which will not only reduce the side of SEGA, but it can also reduce the side of tumors. And apart from that, meaning non-invasively or invasively, we can identify the epileptogenic tumors. And the resection of most epileptogenic tumor will suppress the activity of other tumors, and patient can become seizure-free. Second commonly associated with epilepsy is Sturge-Weber syndrome, in which epilepsy is common 85 to 90% of cases. So we know, like in this patient, they have facial capillary hemangioma, they have abnormal blood vessels in the eyes and in the brain. Like in this patient, it can show tram-track-like appearance in the MRI, in the one hemisphere. Regarding treatment, this is also drug resistant. So most ideal surgery, they say, is hemispherotomy with best outcome. But focal resective surgery, because many times the pathology doesn't involve full hemisphere in Sturge-Weber syndrome. It is also, I have seen 50 to 70% outcome in drug-resistant epilepsy in case of Sturge-Weber syndrome. Neurofibromatosis, which is most common neurocutaneous syndrome, epilepsy is less common compared to general population, which is 1% prevalence. In case of neurofibromatosis, it is 4 to 5% incidence of epilepsy. And what we can see commonly is scapulate spots, axillary unguinal prickling, cutaneous neurofibroma. Now, why epilepsy happens in neurofibromatosis? So earlier they used to say that this neurofibromatosis is bright objects. They are responsible for epilepsy. But as per later the literature come in epilepsy in 2016, what they say is this NFO, neurofibromatosis bright objects, they are more of subcortical. They are seen commonly in thalamus and basal ganglia regions. So the epilepsy occurs in neurofibromatosis mainly because the NF1 gene, they itself have more GABA potentiation, and the seizures are more common compared to general population in NF because of this reason. And lastly, we have Menkes syndrome, in which also epilepsy is quite prevalent. So it is the X-linked recessive disorder, which is females are more carrier and it is more common in male child. It is very fatal, in which they have kinky, coarse, twisted, short and sparse hair. And there can be severe generalized atrophy of the brain in MRI. As far as treatment is concerned, if we know the diagnosis, so there are trials in which they give copper histidine. It is a disorder of copper metabolism. So we can give child copper histidine sub-Q injection before the development full-blown neurological manifestation. So coming to conclusion, my take-home message is hypomelanosis of ETO is third most frequent neurocutaneous syndrome. Epilepsy related to neurocutaneous syndrome, there is very high percentage of these are drug resistant. In general population, what we have seen at 20 to 25% are drug resistant. But in case of neurocutaneous syndrome, more than 50% of seizures are drug resistant. Targeted therapies are emerging from increased molecular understanding, like mTOR pathway in tuberous sclerosis. They have raised the hopes for effective treatment. However, resective surgery of paramount importance, like hemispherotomy and resection, in case of this neurocutaneous syndromes. Thank you.
Thank you very much, Dr. Meir, for this excellent presentation and reiterating the fact that skin and skeletal examination is very important in every epilepsy case. and taking a master class on the neurocutaneous syndrome. I just wanted to ask one question: that how did you manage this patient?
So she is an adult patient. She don't have any
Okay.
weakness on the left side. So
Okay.
hemispherotomy, we haven't given option to the patient. We currently have adjusted the antiepileptics. And she has some amount of reduction in seizure frequency. We have expanded her for vagal nerve stimulation. So it can
Okay.
additionally control her seizures. And we have kept her in follow-up at present.
Okay. We have one question from the audience: that is there a role of prophylactic everolimus in tuberous sclerosis without epilepsy in neonatal or infantile age group?
So in tuberous sclerosis, what they have done currently, everolimus is approved in case of partial seizure with child more than 1 year of age, or there is SEGA in child more than 2 years age. But if before child develops seizure, if EEG is showing epileptiform abnormality, there are data in which they have given everolimus and they have followed up the child with better results. It is also included in renal angiomyolipin.
Yes, Mihir. Actually, there is enough data in the literature. Nowadays, it's very important to screen the newborns for tuberous sclerosis. And if there is, if there are tubers, even without, there is a very nice study where they compared the children who were given everolimus versus who were not given. So those who were given did not develop infant spasms at a later date, whereas those who were not given developed. So now the recommendation is screening the newborn child as well as possibly start everolimus as early as possible.
Yes, ma'am.
Okay. Thank you. I would like to invite other panelists, Dr. C.B. Gopinath ma'am, Dr. Sindhu, Sita ma'am, for their JMK sir, for their expert comment.
Heard everything except everolimus.
Thank you, Mihir, for that excellent presentation. Like a very good, interesting semiology, a very rare case, and good demonstration of the neurocutaneous manifestations of this rare neurocutaneous syndrome. And so you said that you were counseling for vagal nerve stimulation, right? Maybe your pet in the modalities, what was done showed some, like the lateralization was to the right hemisphere, and the PET showed some hypometabolism, which was peaking towards the parieto-temporal region. And the lesion was, yes, diffuse, but you don't have real margins. So like you're justified in like neuromodulation. I just was thinking maybe you may try to find some like focality in that and do some disconnections with callosotomy, etc. Coupled with callosotomy, disconnections of the major part that is involved, whether it is anterior or posterior, maybe in this case anterior. And then if that rates of generalization is high, coupled with callosotomy, maybe you can try for like I'm not saying about a total callosotomy, maybe like because these were more frontal features with the anterior callosotomy, maybe it may like improve or reduce the burden of epilepsy in this patient with already on 7 or 8 drugs.
Okay. Yes,
Yeah, actually, I'll just tell the follow-up. This young lady was given optimization of the medications and finally adding perampanel. Right now, she's on 4 medications. That really made a lot of difference. Now she is on 10 milligrams per day of perampanel, with which her seizures have become now 1 per month.
Oh.
Per month of focal to BTCS. But still, that's why means they also didn't go ahead with VNS yet, though they were counseled. Because I find whenever such, usually VNS is not a great neuromodulation for people with BTCS. So I also didn't push much. They are yet to come for the next follow-up. So yeah, like Dr. CB said, you cannot do a hemispherotomy in an adult. And also partial resections, you need to really do an SCG and find out and whether really it will make a difference is a big debate. So that's why right now best medical management is still the best option. Thank you.
And Dr. Mihir, so
Thank you for the excellent presentation, Dr. Meher. This again emphasizes the fact that general physical examination in any aspect of medicine is extremely important. And in this case, like Madam said, I think the other thing that could have been, that can be done in case she becomes drug refractory is probably localize the exact location with an SPEG or so, and further limited resection based on that, if that is going to help. So that is definitely one of the options, is what I feel. Thank you so much for the presentation. It's very good.
Dr. Mihir, we have a question. And to Dr. Abhishek as well, if he is available, that is there a role of ketogenic diet in both the cases?
The ketogenic diet is it's more approved for children with drug-resistant epilepsy. We haven't much data in hypomagnetism of ETO, but if any patients who become drug resistant, the ketogenic diet will have some benefit.
Not in those with focal to BTCS. I think in adults actually may not be of much help. Children with myoclonic epilepsies and other drug refractory epilepsies possibly it's of help. Yeah, Dr. Sibi?
Especially in structural cases like known MRI positive focal cortical dysplasias, it is not really helpful actually. Especially in adults, it is very difficult, and plus on the top of that, the outcome from positive structurally positive cases is very less. As Madam said, it is more in like the myoclonic epilepsies, the generalized epilepsies, MRI negative generalized epilepsy syndromes.
Okay, I think that we have had two excellent discussions, two very well presented cases, and a lot of learning points. So thank you to all those who could join us. And I would like to now invite Dr. Ajay Asarna, who is the convener of the INYNF, to propose the vote of thanks.
Yeah, thank you, Divyani. At the very outset, thanks to the Indian Academy of Neurology for giving all the youngsters a platform. It's a very good platform for acquiring as well as disseminating and sharing the knowledge that we use in our daily life. I would also especially thank Dr. Meenakshi Sundaram and Dr. Debashish for allowing us to have these regular presentations and share the knowledge with all the IAN young members. Thanks, Ritul, who has been instrumental in bringing this session together. He has been given short notice, but then he has been quite efficient and has got in touch with all our moderators and put up a very nice program for today. So thank you, Ritul. Sindhu, of course, did a very good job with the moderation. Thank you for taking out the time. Your comments were very much appreciated. Especially thank Dr. Sibi Madam for joining us today, giving us our expert opinion and a valuable time that she spent with us. Last but not the least, speakers for today, both of did an excellent job. Dr. Abhishek, we didn't expect anything less from him. And of course, he gave us a very good presentation about especially about the harness protocol, the heteropathies as well as the heteropathies. And knowing Abhishek, I know that he can easily follow this up with a nice little tutorial and a tweet thread, which deservedly will go viral. So looking out for Abhishek's tweets as well. And then Dr. Meher, it was a very good exposition of all the neurocutaneous markers. I'm sure the figures and the case that he showed will stick in memory of most of our residents who have joined us, who will actively look for any such markers in patients with epilepsy, especially refractory epilepsy. Thank you, Sita Madam, also for joining and giving us your comments and your insights on the management of this patient. Overall, thank you all for joining us. I hope this was useful to all of you. And we will be back with more and better programs for you. So thank you. Divyani, thank you once again. You're the one who has set the ball rolling. So thank you once again. And I think we can now close the session for today.
Yeah, thank you. Thank you all for joining. See you at the next session next month.